MAVEN moderator. I'm a MAVEN moderator volunteer. Thank you all for joining us today and our friends at Anchor Clinic for hosting today's session, ADHD and Clinical Management with Dr. Wendy Silver. Dr. Silver is an associate professor of neurology at Columbia University Vagelos College of Physicians and Surgeons. Her areas of interest and expertise include autistic spectrum disorder, ADHD, and behavioral neurology. She is one of the new co-authors of a book chapter on ADHD for the Swayman textbook. And thank you very much, Dr. Silver, for being here.
Thank you, guys. Welcome, everybody. And we're going to talk about some ADHD today. This is the obligatory slide for disclosure, and I have nothing to disclose. And we heard MAVEN is accredited through the Council for Continuing Medical Education. Okay, so ADHD. ADHD is associated with many good things and bad things, right? We know that on the good side, they're passionate, they're fast thinking, they can be enthusiastic, honest, positive. They can hyper focus on things and get things done. They can be imaginative, creative. But we also know that there's downsides to this. It's hard to concentrate. There's impulsivity, hyperactivity in all parts of this. Just to make sure I'm doing this right. So the objectives for today are to describe the clinical diagnosis of ADHD, recognizing the signs of ADHD, the neurological comorbidities with patients with known ADHD, and how to treat ADHD. So we talked about some of the good things, some of the bad things. So ADHD, or people with ADHD, I'd say kids, but these are appropriate for adults as well, because I'm peds neuro, so I tend to use the word kids a lot. So the people with ADHD, they have all those positive things, but they can also have negative things, right? So they can be disorganized, frustrated, easily aggressive. Again, they can be impulsive. They can have a lot of academic struggle. They're not so good socially. They can invade your personal space. They're not, so other kids, and even adults can get frustrated with them. They can have a lot of talking, and they can be very, very disorganized, losing things all the time. I once had one dad tell me every Sunday night they would go out and buy new folders for school because the child would lose the folders, every week. There's also a lot of comorbidities, psychiatric comorbidities, as well as neurological comorbidities. So you see kids with ADHD and anxiety all the time. I have kids, and I have to treat both of those things. We also see children with autistic spectrum disorder. A large percentage, 80 to 90 some odd percent, have ADHD or behavioral type symptoms that fit in the DSM-5 criteria for ADHD. They can have sensory integration, they can have OCD, there's tic disorder, depression, things like that. And then, these things often travel together, although of course you can have someone who is also just suffering from ADHD in and of itself. Okay, so just some statistics for you. We know that ADHD is the most common neurobehavioral disorder of childhood. Worldwide prevalence is about 7.2%. We know that as of 2016, 9.4% of children 2 to 17 years of age had a diagnosis of ADHD. 8.4% of the children had a current ADHD diagnosis. This represents about 5.4 million children. Median age of diagnosis is 7. Boys are much more likely to be diagnosed because they are much more likely to have the externalizing symptoms, which we'll talk about in a minute, which is the impulsivity, the hyperactivity. Girls are more likely to have comorbid internalizing symptoms such as anxiety, depression. 40 to 70% persist into adulthood. So for those of you that do treat adults, you are seeing this a lot. And we know that a lot of undiagnosed adults are walking around out there because this ADHD diagnosis was not as acceptable to have over the last few decades, and has become more acceptable and more recognized. So just trends in prevalence from 2003 to 2011. The top line is males, just in case you guys can't really see. The bottom line is females, and the middle line is the total population. So we're seeing this sort of increase in prevalence coinciding with the acceptance of diagnoses or of the diagnosis, most likely. Okay. So what is the definition of ADHD? So we know it's characterized by a disorder of executive function. There's abnormal dopamine and norepinephrine transmission. It has to do with the frontal striatal lobe, frontal striatal circuitry, which we'll talk a little bit about again. We know that our definition or the concept of what ADHD is based basically on what medications help the symptomology of ADHD. So medications that increase norepinephrine and dopamine help people with ADHD focus, and that's where in a retrospective way, is how we kind of figured out what we think ADHD really, or what the reason for ADHD is. There's some imaging that indicates that perhaps there's reduced volumes in certain areas of the brain. These studies are still ongoing and much more needs to be done with that. Dopamine comes from in in the prefrontal cortex and enhances signaling, improves attention, focus, vigilance, acquisition, and can make people feel like they're more on task. And again, norepinephrine dampens noise in the systems, helps distractibility, shifting, executive operations, behavioral, cognitive, motor inhibition gets increased with this. And we know that people with ADHD have a persistent pattern of inattention with or without hyperactivity and impulsivity that interferes with the functioning or development of their lives, right? It has to cause you an issue or it's not ADHD. So just quickly, I don't want to, dwell on the definition. You guys, I'm sure, have access to it, DSM-5 floating around somewhere. But so part one, you have to have some inattention, six or more symptoms of inattention, up to age 16. Above age 16, it's 5 or more symptoms, and it has to be present for more than 6 months. And that's, you guys can see this list. So, hard to focus and concentrate, hard to get close attention, does not seem to listen when spoken to directly, needs to be redirected at school is the one I hear a lot, right? Easily distracted. At home, parents say things like, I give them something to do, like go upstairs, do X, Y, Z, and they get through X and then Y and Z are never completed, right? They can't really get through a multi-step command because they get distracted. They lose things. I mentioned that before, right? So they're always buying new folders or books or wallets or keys, things like that. It takes them a long time to get through homework or schoolwork more than others because they lose their attention and focus often. Hyperactivity and impulsivity, again, 6 or more symptoms of these for kids up to 16. Above that, only 5, has to be around for more than 6 months. And again, it has to be disruptive to their lives. So, it's that old classic driven by a motor. I really do actually hear that more than I think I will. Sorry. I hear fidgeting a lot. They're always moving. They're always tapping their hands. They're always bouncing around. They never sit still. They have trouble sitting through dinner. Like they'll get up several times while eating. They can talk excessively. They have trouble waiting their turns. They can, interrupt people. Along with this, I also put the impulsive stuff, they can run out in the street. They may or may not have a great sense of danger. And this also comes up with the socialization. They stand too close. They don't understand a sense of self or the appropriate social distancing. Okay. Um, so other conditions that must be met, it has to be present before you're 12, and it has to be in 2 or more settings. So I can't hear from a teacher that the child's an angel and sits perfectly wonderful and hears everything, but the mother says he's the devil and never sits still, or vice versa. It has to be present in both settings. Obviously, for kids, it's easy, it's school and work, school and home rather, and for adults, it's work and home. So it's probably easy to get the information for a kid because you just have to ask the teacher. And often, of course, the teacher might be the initiator of a workup for something like this, right? Because they are having trouble getting a child to focus on something. They are always redirecting them. They always have to call their name. So it's a little bit easier than those with adult onset or adults that had never been diagnosed before. If they're getting their work done, a boss may not notice this, but the patient themselves may notice. Parents, usually confirm this. Again, they can't get a multi-step direction filled. I have to call their name 30 times, although as a parent, I don't know that that's so unusual. Having to call my kid just as quite often, multiple times as well. And then the symptoms can't be explained by something else, right? We don't want it to be something else. And it has to, of course, hamper their life in some way, affecting them, their socialization, their education. There's basic types, 3 basic types: combined presentation, inattentive type, and hyperactive impulsive type. Um, where which are sort of obvious combined, has both hyperactivity and impulsivity as well as inattention. Inattentive type, mostly inattention. It doesn't mean they have no hyperactivity, impulsivity. It means the defining characteristic is the inattention. And the same thing with the hyperactive impulsive type. It doesn't mean they don't have any inattention. It just means that hyperactivity or impulsivity is the main focus. And again, as kids get older, they grow and change. They can kind of fall within different categories at different times, depending on how they're doing. We know that as kids or as people mature, for the most part, the hyperactivity, impulsivity gets better with age, and the inattention is what tends to stay throughout the lifespan. Okay. We know that just this new change that came with the DSM-5 is that adults only need 5 symptoms in each category. So a little bit easier to diagnose now. Okay. What do we use to diagnose ADHD? I have to be honest with you guys, I don't use these tests a lot. Well, the short test, the Conners, the Vanderbilt. If someone shows up in my office, I believe them that why they're there. I don't use these a lot. I have a colleague who loves a good form. He uses the forms for everything, and it's just different style of management. I feel that if you've come to me and the teachers have told mom that all these troubles are at school, mom or dad also endorses this stuff at home. I don't know that I need to do a short form. Yeah, I think I can put it on my billing and get like a whole whopping quarter of an RVU or something for it. I don't know, maybe Columbia gets $4 per test. I just don't know that I need to delay the diagnosis, which is what I feel by making them go and get the forms and then come back. I'm booked out like crazy. I don't have time to have them come back in 4 weeks when I'm booking out a year. It's very difficult. So I tend not to use the forms unless the parent insists. So if the parent insists, I use the forms. I use the Vanderbilt a lot because it's free. The Conners I do like to use if the child is old enough to do the self-assessment, because there is no self-assessment for the Vanderbilt. If I really question the diagnosis or I think that there's other learning disabilities like comorbid dyslexia or math, primary math disorder, another primary reading disorder, writing disorder, I do send them for neuropsychological testing, but I'm not going to delay the ADHD diagnosis if I think it's clearly there. If I'm not sure, is this really ADHD? Is it just severe anxiety, which sometimes I can suss out myself in the office. But if I'm really not sure, I'll send them for neuropsych testing, which I'm sure you guys all know is easier said than done. We do have some places here in New York that do sliding scale, but of course those all have year-long waits, and private pays quicker, but a fortune, thousands and thousands of dollars. Okay, so what are things that I do? I don't just jump to medicine right away. I generally talk to the parents first. I talk to them about what are we gonna do? First and foremost, I'm gonna recommend them getting a 504 plan or updating their IEP. These are things that are part of our school. What they have an IEP is individual education plan. A 504 is like an IEP light. And these are the things that get your kids accommodation and services at school. Again, adults don't really have an equivalent of this, but and on the 504 plan or the IEP, you want to add all of the supports and services that you can think of that the kid wants. So I have all those things written down there. Chunking is breaking things up into smaller packets. So for instance, like sitting for 5 minutes, taking a break, or handing someone who with ADHD only one, I'm going to use an old word, ditto, one photocopy of an assignment, and then they get up to get the second page from the teacher, so that gives them a break. It also doesn't overwhelm them by giving them 5 sheets of that they have to, 5 like math sheets that they have to do, for instance, in a row. But not everybody needs all these things. Extra testing time is fine. Some people don't need it. I am a big fan of the short break, I have to say. A really big fan of giving the kids just like a few minutes to get up, shake it out, get the willies out, and then come back and sit down. I do that with homework also. It says, if you look over in the homework side, it says using timers. That's what the timers are for. You have the child sit there for 10, 15 minutes, or if they're little, it may even be 5 minutes, depending on their age. And then they get a break. Sometimes the breaks, again, if they're very young, could be bigger than the time they sat to do work. And then the timer goes off and it's time to go and sit back down. The earlier you start that with the child, obviously, the better you are at developing good habits. So you want to start this when they're as young as possible. And then when they're in high school, they're doing 30, 40 minutes of work and taking no more than a 10, 15-minute break. Otherwise it gets too wieldy. I love color coding. I'm a big fan of checklists. I'm old fashioned about it. I like you to write a list, either laminate it or put it in a page protector. Get yourself a dry erase marker, hang it on a wall. I usually start with one list and work our way up to 3. So for instance, you start with an after school list, putting all the things that you need to complete after school. It can be as detailed as needed. It can include even coming home, going to the bathroom, washing our hands, having a snack, setting a timer for 30 minutes, then all the different homeworks you might have for the year, and ends with, make sure you pack up all your stuff for tomorrow, or upload things to Google Classroom. And then you, about 3 months later, you institute a second list. I don't do this all at once because it becomes overwhelming for the parents. It sounds really easy. Oh, this is going to take 5 minutes. It's not so easy. Parents are working. Parents are tired. We want to do this slowly so they all get used to it. 3 months later, you start a nighttime list. The first thing on the nighttime list is, are you sure you've really packed up all your stuff for tomorrow, or upload it to Google Classroom? And then whatever they do at night, shower, brush teeth, read for 20 minutes, get a glass of milk. And the child is supposed to write the list with the parent. If they're too young to write, that's fine. Mom writes it, but they sit down together and they create these lists. The kids can decorate them. And then again, we hang it on the wall and it sits there. Morning list, same exact thing. For the morning list, I'd like to add in time if the parents think it's going to be helpful. So I have them write like, socks must be on by 7:05, shirt must be on by 7:10. And have them go to Target, as we call it, good old Target or whatever, Walmart, whatever's near anyone, and get an old, an analog clock for $10, write with Sharpie So when the minute hand is at 7 o'clock, it should say socks. When it's at 7:05, it should say shoes. Whatever their dressing order is, and that way the kid can see it. They do sell very expensive versions of this, but I don't believe in spending other people's money, right? We're gonna go the easy, most inexpensive route to help these kids. So you can have this clock with the Sharpie written about when your timing it is, and you have your list, you do your check off. And the important thing is for them to read it and do the check off. Even if they're little, mom can read it or dad can read it, and the child still should do the check mark. Why? We want to build muscle memory. We want to build this in as a routine for these kids. We want them to read their list. We want them to check it off. We want it to get into their bodies. What I always see is we're building an external scaffolding because they don't have that internal scaffolding that people without ADHD have. So we're trying to organize them. The last thing on your morning list is, are you sure you really have everything packed up or uploaded for today? So 3 times we're reminding them to bring their stuff. These kids lose points because they leave their homework home, even though it's done, it's sitting on the top of the table. So we want to remind them to bring it. And again, we're taking almost a year to, or 9 months to get these lists going. Kid's gonna love it for a week, then they're gonna ignore it and hate it. I tell parents, we're not gonna fight about the lists, but we are gonna leave them on the wall because guess what? It's a visual reminder. Even if they're not using it, they do see it, right? You're reading, everyone's, eventually you do sight words, they can see what it says. And on good days, when we come home happy from school, when we're having a good night or a good morning, we do our checklist. So we try to use it as much as possible, and we leave it on the wall in between when we're not having a good time. And I do tell parents also this too, cognitive behavioral techniques, cognitive behavioral therapy do not work in 3 months. They work in years, right? Years and years and years it takes to change behavior. If it was easy to change behavior, we'd all weigh 120 pounds, have great muscles, and jog for 5 miles a day. We do not do that. Why? Because it takes a lot to change our behavior, our innate way of being. So we're talking about using these things for years at a time, not months at a time. I love color coding for kids in high school and middle school. Each class, starting in 6th grade, I have the kids pick a color. You want your math to be red, fine. Math is red from 6th grade to 12th grade. That's it. Notebooks, pencils, binders, folders, all should be the same color. And that way, when they go to their locker or they're carrying stuff in their book bag, they see that color, they know it's math, that's it, they're done. We want to do simple things and we don't want to do too many things at once. I usually start with the timer and the checklists. The timer, again, it's just to break things down. I also have them use it for things like shower. 30 minutes till timer goes off, they know it's the 30-minute warning for shower. Timer goes off again, it's 10 minutes or 15 minutes, however the parents think is doable for their home, right? And then the color coding kicks in again if they're in middle school or high school. You want these kids to have a routine, right? And the only rule I do have is during those breaks when they're doing their homework, if they do take a break, absolutely no TV, no iPad, no iPad or TV when getting ready for school in the morning. We all know we pick up our phones. Probably some of you are looking at your phone right now while I'm talking, right? We can't help it. We pick it up. Every morning I go to look at the weather and I check my email instead. And then sometimes I walk out and I get rained upon because they're very distracting. After they're done with their homework, they can do their iPad, they can watch TV. Those breaks should be something else. If they live in a house, I'm in New York City, so a lot of my patients live in apartments, but if they're in a house, I'm like, go run around on the lawn or play basketball in the driveway or jump up and down. It's a little harder in an apartment building, but there's stuff they can do, draw, color, read a book, bake a cake. I don't care what they do during those breaks, but especially really no electronics. TV, I don't know, nowadays you can pause Netflix or whatever, but and it doesn't seem to suck you in as bad as YouTube and the other electronics, games, things like that, right? And we're going to check our backpack. We're going to make this all part of our routine. So that's the first thing I discuss is, getting them help at school and doing some stuff for them at home. And there's tons of other ideas, cognitive behavioral things. These are just the ones that I like. The American Academy of Pediatrics has stuff on their website. I don't know if the government still does, but it used to. Okay, so the third part of treating them is medication. Now, sometimes, I'll start right away. Sometimes I don't start right away. It really depends on where they are in treatment. If a child already comes to me and they have a 504 or an IEP, they're getting all these supports, they've been in cognitive behavioral therapy for 3 years, they're really here to see me for medication. If they're just sort of starting out on this process, I may still offer it if I think it's reasonable to start the child on it. But if the child is still doing well enough and we're going to work on these habits, trying to get them in a good routine, I may say, I think we can wait a little bit on meds if you want to. If it's bad enough, where the child has already failed a year of class and they shouldn't have failed a year of school, they have 110 IQ. Should they really be failing school? No, obviously this is really not great. They've already had, neuropsych testing. That's how we know their IQ. We know there's not a lot of other things going on. In that case, medication seems to be, something that we should do imminently as opposed to waiting. All right. So we talked about this a little bit before. Oops, sorry. Now it's working. A little bit before, where, what are we doing with medication? So we know that our prefrontal cortex regulates attention, behavior, emotion. I'm very emotional, so maybe mine's not so great, but and that deficits in the functioning of our prefrontal cortex have been linked to ADHD, poor impulse control, weak sustained attention, heightened distractibility. We've all heard about people who had frontal cortex injury, right? We know that norepinephrine and dopamine are the key neurotransmitter for functioning in our prefrontal cortex, and there's sort of an inverted U dose response. And I have a nice image graphic coming up for this. And we know that these sort of the catecholamines here, the mechanisms of action have been suggested through the medication pathways that I just saw a big typo, fasciculate attention. No. I have to remember to change that. That we know because of the mechanisms of action of the medication that help, that we think these are the pathways that we have to work with. Okay. So this is a great illustration that I found online from the Psychopharmacology Institute. So, and it shows the relationship between dopamine and norepinephrine, and what response. So we're talking about too little dopamine and norepinephrine. Sorry, I don't know why that, I don't know if you guys can see it, but I don't usually have that little box up there. There we go. Our kids with not optimal, hold on, let me go back, not optimal behavior, right? So they have too little dopamine, too little norepinephrine, their frontal striatal cortex is not working great, and this shows in their behaviors. If you are on the top of this curve, you're doing pretty well, you're functioning, your prefrontal cortex is great. And then if it's too high, too much dopamine, norepinephrine, we are in a stress state, and this shows itself in other behaviors and ways. Okay. So the dopamine transporter system, oh, sorry, I keep trying to get rid of something, but it's not working. All right, yes. Sorry about that. I'm trying to get rid of something that's blocking some of my stuff. But so DAT is the dopamine transporter. The NAT is the norepinephrine transporter. And we know that the most classic medications that treat ADHD, which are the stimulant medications, methylphenidate and amphetamine, work in these in our on these neurotransporters in the synaptic spaces, and they work on presynaptic neurons. So methylphenidate modulates the activity of DAT and NAT, and it inhibits the reuptake of norepinephrine and dopamine. Okay, and therefore it leads to higher levels in the synaptic space. So methylphenidate, the big difference between amphetamine and methylphenidate is methylphenidate does not release dopamine from the synaptic vesicles, where amphetamine does promote the release of both dopamine and norepinephrine from synaptic vesicles. So methylphenidate just blocks reuptake, but amphetamine does both. All right, this is a crazy busy list that's getting busier and busier as we get new medications. These are just, I think I'm up to date. I tried to look to see if there's new ones. They sneak out on me sometimes, even though I think I hear about most of them. These are methylphenidate derivatives and amphetamine derivatives that we have out now. There are some new ones. The new medications are really just derivatives or similar to the old medications. For the amphetamines, there's different amounts of amphetamine salts mixed in, different proportions depending on the medication. The newer medications, basically the formulations are different, right? So this is liquid. We now have long-acting liquids for both methylphenidate and amphetamine. Or is it something that's dissolvable? Is it something, for instance, Jornay, which is a methylphenidate, you take it at night and it doesn't release till the morning. And this is one of the new ones that I've actually used. I don't use a lot of the new ones because insurance does not improve them, but I have used Jornay PM a few times and have actually been successful in getting it approved miraculously. And you give it at night, and what it helps is that morning routine. A lot of parents have trouble in the morning. It's a big deal. The kids are not getting out. They're not going to school. So that Jornay PM that kicks in the morning is great. Although I have had parents say, the bad part about it is their kid is up at 6 a.m. no matter what day it is, whether they have school or not. And then there's a very long acting one. My day is on the amphetamine side, which is supposed to do 16 hours. I've not been that successful in getting that through the prior auth departments at this point. But it's supposed to be 16 hours, which would be great for certain people, who have very, very long days, whether at work or at school. Right. These are just the different formulas really quickly. We know we have some long-acting liquids now. Like I said, there's some chewables, there's sprinkles, patch still around, and then there's the short-acting are crushable. Concerta is hard to use in small kids because it's a caplet that you have to swallow whole. The interesting thing is we're now finally getting liquids and chewables and things like that, and most of them are not generic yet. Even though these are primarily started for kids. So the older medications, what's great about them is they can be open and sprinkled. And some of the new ones can too, as you can see on the list. That fix my Jornay PM there too. So there's some non-stimulants, atomoxetine, which is Strattera, that works primarily on norepinephrine, and it has some secondary effects, increasing prefrontal cortical dopamine, sorry. And then alpha-2 receptor agonists also work on the prefrontal cortex. And then brand new one called Qelbree, which is viloxazine, is a selective norepinephrine reuptake inhibitor. Okay. So, and these are basically what's out now of the non-stimulants. So we have the alpha agonists, short-acting, long-acting. There's a new one called Undina XR. It's once a day. It's equivalent to clonidine. And it's supposed to be 24 hours liquid, which I think will be great once we can get it generic in a million billion years. Supposedly has good efficacy from what I hear. I'm also looking forward to trying it into kids with autonomic conditions. So again, Strattera, long-acting selective noruptake reuptake inhibitor. We have some short-acting ones. short-acting NDRI is Wellbutrin or bupropion. There's a long-acting version as well. And then the Qelbree, which is the new one. And we know these work. From what, and this is very anecdotal, although there are some articles on it as well. I find that the non-stimulants seem to work, help with the impulsivity, the hyperactivity, but the focus is not always so, it's not usually helped as much, so that the kids still have focusing issues on these non-stimulants, although some kids do better than others. And I like a combination of a long-acting alpha agonist with a stimulant, and that seems to work really well. Then after this, I go into some cases. I don't know if anyone has questions before we start the cases. Cases are quick. I don't see any chat, so I'll just keep going. Case-wise, we have a 9-year-old girl. She's otherwise healthy, normal exam. Her only complaint is it's hard for her to pay attention in class. There's no misbehavior. She's not getting in trouble. Her full scale IQ is 110, but she's doing very poorly in school. Teachers need to redirect her. Sorry about that. And it takes her several hours to do 30 minutes of homework. She loses things. She forgets to hand in her homework that she does do, so she's disorganized. She's always had problems, but now she's hit 4th grade and things are really, really not doing well. So things that would, what do we consider when we're choosing a medication? So we're not hearing anything about anxiety, so that's good. She has a normal IQ. She can do well in school. She's done well up until this point. So there's less likely to also have been sort of a learning disability, dyslexia, or reading disability along with this. And seems to be, sort of a case of sort of, I call it simple ADHD, right? And she doesn't get in trouble. She doesn't act out. So there's not a lot of impulsivity, not a lot of hyperactivity that's being described here, right? It's mostly inattention. So we would probably diagnose her with ADHD inattentive type, and then offer treatment. And again, first line would be stimulants unless there was a reason not to offer stimulants. I want to also mention, which I have not mentioned before, is why do we really, want to treat these kids? Evidence shows that kids with ADHD who are treated do much better. They have less depression, less suicidality, 50% less illegal drug use to self-medicate, and better self-esteem. So these kids really do become aware of, why am I different? Why do I get in trouble all day? Why does Joe sitting next to me not get in trouble? Why is the teacher calling my name out? So there really is great evidence for treatment. If you look at the long-term outcomes of treatment, it's all positive. There's no negative, there's been nothing negative found. I'm not saying that there can't be, short-acting side effects, right? It can affect someone's appetite. It can affect, sleep. There's things like that. There are always short-acting side effects of medication, but long-term outcomes have been positive, not negative. There's even some newer studies that indicate that there is possible rewiring of the brain in a positive way from people who have been on medication for many years. There's no real negativity. There was 1 or 2 studies that showed maybe possible growth, but obviously we would keep an eye on growth, make sure they're eating and growing, the kids. And then we talk about high calorie, smaller portions if it really does affect lunchtime, because they want to keep their growth and their nutrition up. If it's really bad, there are ways around that also. But but the positive effects, these positive psychological effects of less depression, less suicidality, better self-esteem are really, really important. And the sooner you catch it, the earlier you catch it, the better the outcome. And again, these meds have been around for over 100 years. Now, granted, we don't have studies from back then, and they were used in many different ways, but studies have been around for decades now, and really only show positive outcomes. Um, and some kids do better than other kids. Some kids can come on and off the meds, like they go off for weekends or they stay on for weekends. Some kids don't do well when they come off. They do have a withdrawal effect. Some kids can come off easily. Some kids don't do well when they come back on. For instance, on Monday, maybe they'll have a headache because they haven't taken the med over the weekend. But these things can be worked out. If a kid doesn't eat lunch and they're losing weight, like I said, we encourage high calorie smaller portions of something. It's very easy to find high calorie things that come very small portions. It's very hard to find low calorie large things that are delicious. It doesn't work that way. So, or what we can also do is then instead of using a long acting med, we can use a short acting med, right? So yes, it's a pain in the neck to give a child a midday medication at school, but it can help them eat lunch. So the early morning one wears off, they eat their lunch, and then they take um their second dose after lunch or during lunch so that they're ready for the afternoon, and that's a way to mitigate weight loss. Same thing with lack of sleep. Some children don't do well with lack of sleep. And then again, changing to a short acting can help mitigate that as well. The other thing that is helpful is a lot of these long acting meds purport to work for 9 to 12 hours. They often don't. We often use a booster for after school, so that a long acting with a short acting booster after school. Very, very rarely, probably a handful of times, I've had children who the long acting lasted so long that it kept them up for 24 hours. We were able to actually put them on a short acting, and that lasted them throughout the day, which is super rare. It is much more often that they're metabolized quickly and that by the end of school, they are needing a booster to get through homework, or even the last, sometimes it's hard to get through the last couple of classes, which is also why going back to things that we can do for an IEP or a 504 is we want to schedule the harder classes in the morning. Math should be in the morning when the meds are in there and they're fresh. And the last class should be art or gym or something that the child enjoys more or has more movement for, where they don't have to sit still and listen. As you know, it doesn't require that's the same kind of focus that math or English or writing has to do. So someone like this child, she's 9, she's otherwise healthy. We would want to start a stimulant on her. Um, so this one is easy. I love when they come in with a neuropsych testing that has them diagnosed. And mom is also reporting that he has anxiety. He has a 504 already, but he's just not succeeding with just accommodations alone. There's no behavior issues, but he can become very emotional and distressed when he's feeling overwhelmed. He tends to act out. He doesn't like when he doesn't finish things. He gets upset when he gets things wrong. So there's expressing a lot of anxiety with this child. His self-esteem is becoming poor, and he does have, normal testing, normal, IQ. What I do with these kids, and I see them a lot more than I expected to see them, coming out of residency. What am I going to ask him? What I do with these kids where the anxiety is probably as bad or maybe worse than the ADHD is I ask them about it. And I always say, and I think you guys can see me in the corner, I hope. I always form a little circle and I explain how both anxiety and ADHD feed off each other, right? So if you're anxious all the time and you have an internal, dialogue in your brain that's distracting you, that's going to cause you to be inattentive. Is it just anxiety really that's causing inattention? Do you really have ADHD? Sometimes it's hard to know, but we know that these two things are really, really comorbid with each other. They really travel together. Same thing with ADHD. If you know you're going to walk into class and they're going to say to you, John, 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 all day long, pay attention, pay attention, pay attention, and you see the other kids are not having trouble, that's going to cause you anxiety. You don't want to go to school. These kids, sometimes they don't like school because of this. So I tend to ask both the parent and the child, hey, what do you want to start with? You know, what's worse? Is your anxiety worse? Is your ADHD worse? Are you just is also the anxiety only around school? Is it just because of these issues? So maybe it's situational anxiety, and if we fix the ADHD, we can then fix your anxiety. Your anxiety might go away if you can pay attention and focus, and that's all you really were worried about. Maybe it's not general anxiety, but if you're also worried about, you know, if mom and dad go out in the car, are they going to come home, or they're anxious about friends, or they're anxious about this, you know, and there seems to be a true anxiety, sometimes treating the anxiety may not completely help the ADHD, but it can also make it better, right? So we know these things, it's a feedback loop, and we want to treat the thing that's causing the most issues, or the primary problems. And it doesn't mean they're not going to end up on medication for both, but they also, by treating one, you can often help the other, at least to some degree. So, and a kid like this, we may not start him necessarily on a stimulant medication. Maybe I'm going to start him on an SSRI first and then add a stimulant medication, or maybe even a non-stimulant medication. You know, clonidine, guanfacine, the alpha agonists do have some anti-anxiety properties. They're obviously not anxiety medications. I certainly wouldn't use them to treat just anxiety or primary anxiety, although they can be helpful with OCD symptoms. But maybe an alpha agonist would be something that we would want to start him on to help the ADHD first, and then we could possibly add in a stimulant later if it's not enough. Or does he need to start with an SSRI, get the anxiety under check, and then maybe add in something for his treatment of his ADHD? Each, you know, child is different, and listening to them, and if they're someone who can express themselves, it's always so much easier to treat them, right? Kids who are either too young or don't have a good handle on their own emotions or their own issues, it's harder because I've had kids that come in and say nothing's wrong, you know, and then they're in denial, even though the parent is here saying it's impossible. Here's 47 teacher reports that this kid is, you know, can't pay attention. And some kids don't have the ability to recognize when something's helping them or when something is not helping them, and it always makes it a little bit harder. Okay. Um, so this little guy comes in, he's bouncing around in, you know, talking a mile a minute, constantly in your office, touching things, opening drawers, opening cabinets. He's he's taking things out. He's got your, you know, your reflex hammer, and he's banging it all over. He hits mom, he hits you. He can't sit for dinner. He's just constantly in motion. He'll take a few bites of food, he'll then run around the house. He's in kindergarten. He's starting to drop behind the other kids in the class, even though, quote unquote, he seems to be a bright kid, but he just can't sit and pay attention. So these are the kids that you're going to see earlier, right? This is hyperactivity and impulsivity at its, you know, best. Um, you know, these are the kids that come when they're 3, 4, 5. I've even had 1 or 2 2-year-olds, where they come and they really, from the get-go, cannot sit. They cannot focus. They're not going to learn if they can't sit and focus. And there's a few barriers to treating this child. Number one, he's 5, and if you look, almost none of the stimulant medications are approved for under 6. You can kind of sneak in some non-stimulants. the guanfacine and clonidine I've been successful in getting for kids. I've been successful in getting stimulants too. It often requires a prior auth and me explaining that there are no things approved for this child who is running out into the street and is gonna, get hurt if we don't get him on medication. So please approve it, even though he's 5 and not 6. Had that happen a lot. Um, you know, and what else is a barrier? He's 5 years old. Is he swallowing pills? I don't really, not, probably not, right? So the non-stimulants, except for now Qelbree, which you can open and sprinkle, but it's brand new. It's still name brand. It's hard to get approved. You're certainly not going to get it approved as your first line medication. Strattera is a capsule. You're not supposed to open it. It can give you esophagitis. So you're talking about crushing short-acting clonidine and guanfacine multiple times a day. If you can get a stimulant, especially a long-acting stimulant approved, that would be great. The generics, like I said, for the most part, you can open and sprinkle. Vyvanse is now generic, which is great. It's supposed to disappear in water even, and dissolve fairly well. So we can get that into a 5-year-old. I treat a lot of children with autism. This is also a huge problem, getting medication into them, that's bearable. So his age, he's not gonna be able to swallow tablets. All of these things are barriers to treating this child, but he obviously needs to be treated. Like I said, there were some newer studies in the last few years on toddlers, and using alpha agonists that seem to be pretty, enlightening, seem to show that they are helpful in toddlers, excuse me, with ADHD. And, and you can crush the short-acting ones, which is what's helpful. And they're very teeny if you break them in half. You can put them in, I have parents put them in peanut butter ice cream. A tablespoon of ice cream is not going to kill your toddler, even if it is 7 in the morning. And they can get them to take it. So you're going to have to use you might have to, have tricks if they don't like that it's crushed, that kind of things. And again, I do a lot of, treat a lot of children with autism, so I'm always trying to think of ways to get meds into people who don't want to take meds. The patch can be useful in some kids if they're not going to pull it off. It can be dangerous that they pull it off and put it on somebody else. Things like that. Like I said, I'm looking forward to when the liquid clonidine has been around for a while. Although I do tend to use guanfacine more than clonidine because guanfacine is less sedating. I use clonidine a lot for sleep at night, probably more than I do for ADHD, but I have had kids where the guanfacine doesn't work or disinhibits them, and the clonidine works better, and doesn't make them that sleepy, which is good. And like I said, I'm looking forward to this long-acting liquid clonidine for years in the future to actually become generic eventually, even though it just came out like 4 minutes ago. Okay. So, kids going off to college, you have teenage patients, they've been on stimulant medication, they've in great control, they're going off to college in the fall. I always make sure that they come into my office before they go off to college, and we have a long, frank discussion. What are we talking about? We are talking about the fact that they are going off to college and stimulants are worth a lot of money, right? On the black market, or if that's even a term they want to use now, on the street. And people will want their medications, right? These are meds that have value. People will steal them. People will beg you for them. People will say, I'm not hanging out with you unless you give me one of your meds. And I basically tell them that it's better not to get into that situation in the first place. So no one knows you're on these meds, your boyfriend, your girlfriend, your best friend, your roommate, I don't care who it is, how much they love you. You wear each other's underwear, you're so close. I don't care. Nobody knows you're on these medications. You go off, you bring a lockbox, you have it in your room. You even can take the meds while you're brushing your teeth in the morning in the bathroom so no one sees you doing it. And it's not because we're embarrassed, and it's not because there's something wrong with you taking these medications. It's because they are liable to get you in trouble What if someone steals your meds, takes a handful, and has a heart attack and dies, right? We know overdoses of these meds happen. What if someone's allergic? What if you give your friend a pill and then you don't have enough for you? I can't renew your meds before your 28 days are up. You're fresh out of luck if you don't have your meds. I can't do that. Right, so there's these can be dangerous. Obviously the non-stimulants, we don't have these same issues. I also review their medications with them to see if their regimen is still going to be helpful. Are these kids that really want, it's really only when they're okay for a 1 hour class. They're not sitting anymore for 8 hours in college, right? They're now sitting only for 1 hour class or at most a 3 hour class. Maybe they can sit for a 1 hour class without meds, but they really need meds to study at night. So maybe we're changing them from a long acting to a short acting, where they use the short acting as needed to get their studying in, or for that 3 hour class, but they're okay in their 1 hour class. Sometimes I have them go through the first semester of college, and then we change the medication depending on how they how their first semester goes. Do they really still need what they're on? And I have other kids that they just know being on their medication helps them focus and pay attention. Without their meds, they are a mess, right? They want to know what's going on. And they don't want to lose things. They want to keep their stuff together, I'll say. I won't use the bad word. And they are just on their long-acting medication every single day. It helps them function. It helps them keep their lives together, and they just are on their long-acting meds, forever. This is another case, but I know we're kind of running out of time, so I wanted to ask if, again, if there's any questions. If not, I can just do a last case really quickly. I don't see anything in the chat, but I don't
Dr.
know.
Silver, I had a quick question.
Sure.
What's your thought on the gene testing to determine which medication might be a good starting option?
So, last I checked, they weren't actually doing the ADHD meds. It was more like SSRIs, things like that. And I hang out with a lot of psychiatrists just because of what I do, and really no one finds them that helpful. I don't know that we're there yet. I do have friends that use them, if they've tried every SSRI or every antipsychotic, like where they've tried 3 or 4 and were really not successful. So I have had people use it. I have had parents insist upon it, and I've sent it, and because frankly, they do everything. They do the insurance auth. I just fill out a little form, put the name and address of the parent, the patient in there, with all the information, and they contact them. I'm actually waiting for a set now, actually. It's only like this third or fourth time I've done it though. Again, it doesn't seem to be that helpful, and they're not, I think I said the last time I did it, they didn't even include the ADHD meds.
They do now. I've seen it on a couple ones
They,
recently for my
yeah,
patients, but I don't know if it's certain companies or not.
yeah, the one we use is what, Gene Sites? I think
Hmm.
that's the big one, and they might now include the ADHD meds. The last time I did it, they didn't, so we'll see, but I'm getting a new report shortly. So we'll see, we'll see. So
We do have
question,
another. Oh, sorry.
oh yeah, sorry, a question came in.
Yep.
Approach to parents request for ADHD medication when there's clearly, so with opposition, when there's clearly underlying oppositional defiant disorder as well as ADHD. It's tough because they think the meds are, I always say these are medications, they're not magic. And and also my goal isn't to change your child into a Stepford child. We want them to still be themselves. But I think it can help to some degree, but obviously ODD is not medication responsive. They need therapy. But I do find that it can help with the the impulsivity, and usually, at least most of my kids that have ODD also have ADHD. It seems to run together. I just got a neuropsych report today actually on that with a kid with, ADHD and ODD. So I will try medication, see if it's helpful, but they have to be in therapy also because ODD is not gonna respond to medication. And the next question is, what is your opinion on young patients using recreational marijuana at the same time as Adderall? Okay. I have to say I'm not not to use a pun, a maven on, marijuana use, but I'm not a fan, right? So, um, we know that, I mean, they kind of do almost the opposite of each other, right? So I highly, and that's the other thing I do when kids go off to college, I didn't mention that, is I give them you're not supposed to drink on these meds, really. They're not great, it's not great for you. And also using using illicit drugs. And particularly recreational marijuana is so common now when it became legal. Um, and again, I'm not a huge marijuana maven, but we know studies show that it, decreases attention, makes you sluggish, makes you less aware, all of those things. So it's the antithesis to what we're doing with trying to give you medication. So, I do try to warn them, as much as I possibly can. I don't know that a young person listens to anyone, frankly. I don't know how much I listened when I was young. But I do try to, um, warn them that this is really not going to help you and, be a better student. Let's put it that way.
Dr. Silver, we have
Any,
somebody
yeah.
with their hand raised. So
Oh,
Charlotte,
sure. I can't see people. So,
Charlotte,
oh, there we go. Now I can.
Charlotte, you have the ability to unmute yourself now if you'd like to ask your question. Hold on.
I don't have a question. Sorry about that.
Oh, it's
It
okay.
happens.
Um, so I mean, any other questions, I'm always happy to answer. And obviously, everybody has my email. Oh, there was something that came here under the questions. Okay. Okay, so I'll read the question. It says, you emphasize the ADHD needs to be affecting the child's life, particularly performance at school. I know a 6-year-old boy with many of the hyperactive symptoms you mentioned, alongside with periods of separation, anxiety, impulsivity, etc. Some facial tics, eye rolling, very bright, gifted, athletic, but he's doing well in school and not having major impacts of life. So what do you do for this kid? Is he just ADHD or is he an active boy? So it's hard to tell sometimes. I do see brighter kids that come in later, right? They're able to get through school. They make it to 6th grade or 9th grade. And what I would, and if it seems like there's 2 ways to do this. One is he's got facial tics and eye rolling. We don't always, and I'm sure most people know this, we don't generally treat tics unless they're interfering in the child's life or they're bothering the child, because they often bother the parent. But tics are benign. However, they can have implications, social implications, we treat for that, and also physical implications. If you're turning your head all day, you get neck pain, that's not great either. So there are reasons to treat tics, but if they're not bothering the child, either again, socially or physically, we tend not to treat them. This kid, it's hard. So while he's a super bright kid, how's his home? Is he unorganized? You could just try a non-stimulant because it might help the facial tics. Sometimes I'm willing to try something if we think it's really there, even though he's doing well. Is he getting 90? Maybe he should be getting 98. And this is a kid too. Maybe I would send him for neuropsych testing if the parents if you can get it done. It's hard. It's really hard to suss out these things. You mentioned some separation anxiety. If it's really just separation anxiety, it's probably not at least consistently interfering in his functioning, right? Because it's situational anxiety, which is usually responds to therapy of some sort. But if we really feel, that this is going on, so I might start with, instead of medication, because he's still doing okay, the parents are not coming to you ripping their hair out of their heads. Oh my God, I can't take it. He's all over the place. He's can't fall asleep till 3 a.m. I would start out with maybe some cognitive behavioral stuff first. See if that can help him, organizational stuff. See if that works well. In school, even though he's doing really well in school, are the teachers still redirecting him just because he's doing well? I have kids that do well because they're bright. They come in, they're just getting A's, but the teacher is calling Johnny's name every 10 seconds. So I would, find out more. Are the teachers seeing, this inattention in school, this hyperactivity? Is he always getting up despite the fact that he's getting an A? And then maybe it would be worth treating for that. Or like I said, at least starting some cognitive behavioral stuff, which I feel like can be really important to do. And keep a very close eye on them. Are things starting to slide? But I might, again, get those teacher reports, see what they have to say. Is mom, again, needing, telling him 47 times to sit down for dinner, and then he gets up 37 times. That, just because being bright can mask for sure some of the symptomology. And those are the kids that come in, like I said, later and later and later, as opposed to, when they're 5 and they're not doing well. Even though you said he's 6, yeah. The kids that don't do well with this are the ones that show up sooner. Any other questions? I think.
There's a couple of questions in the chat. Someone asked about marijuana helping with hyperactivity.
I mean, like I said, I'm not a marijuana expert in any way, shape, or form. I'm sure it could, because it gives you amotivational syndrome, and maybe you're not hyper if if you're not motivated. But honestly, I don't know much about marijuana use. Venlafaxine and Cymbalta. I don't know of any recent studies on those. The one that we use the most is bupropion, which does have approval for ADHD. It might, there's a lot of crossover with medications that affect neurotransmitters. So something that is a SNRI, like Cymbalta is an SNRI, right? That increases norepinephrine. It may, I don't know. I'm trying to remember, because again, we just wrote this book chapter. I don't remember them being particularly on the list, but they could be. And they do increase norepinephrine, so it's possible, is what I would say. I know bupropion for sure has approval for ADHD. I don't think it works that great, but I have used it when all else fails. Child who's struggling in school, parents have joined. Ay, from one day. Ha ha ha. Okay, so this is really common, unfortunately. So the question is, the child diagnosed with ADHD struggling in school, parents have joint custody. One wants medication, the other is against it. What do you do? I unfortunately am very familiar with this. It's really, really hard. If I really think the child needs medication, I'll try to talk to the parent. For good or for bad, it's almost always the dad that doesn't want medication. I don't know why it's almost always the dad. I will try to talk to them. Oftentimes the mom is the one that brings them to your office, and the dad's hearing things second or third hand. I try to talk to the parent, again, I'm going to say dad, but the parent that's against medication, and explain, like, this is not something we do lightly. I take it very seriously when I prescribe these meds, even though I have thousands of patients on meds. It's what I do. I go over the other steps that we're going to take, right? Yeah, it's dad. It's always dad. I go over the fact that we got the 504. I go over the cognitive behavioral methodologies, right? I try to show them that we're not like these pill pushers or whatever they think we are. I try to explain, look, we're trying all this, but do you see that your child is struggling? I explain to them that I am not the wife's doctor. I am not your doctor. I am your child's doctor. I am trying to do what is best for your child. Your child is struggling. Do you see that? This is the report from the teacher. Use as much evidence as you can. The teacher says Johnny is unable to sit in his chair. What happens at your house for dinner? Now, the dads always say, oh, for me, he's just great. I don't have any of these problems mom has. First of all, I don't buy it. Second of all, dads have deeper voices. We know deeper voices are scary. This has been shown. There are studies, right? So maybe the child holds it in better at dad's house. But we and I just try to explain to them, and I try to talk to them firsthand if you can, call them up. It's not like we all have that much time in our day. And I know we all spend lunch doing these things. This is what I do at lunch, is like call back families, or I portal them back, or, and I try to explain, this is my reasoning, and this is what, and I try to tell them those studies. I quote the less depression, less suicidality, better self-esteem, less illegal drug use, because they're all worried my kid's going to become a drug addict. And I'm like, no, 50%, 50. I wish I don't have the paper that has the numbers, but they're probably Googleable, if that's a word. 50% less illegal drug use for kids who are treated. That's enormous. Nothing in medicine is 50%, right? So I try to, just give them the facts as much as possible. It's hard. It's really hard. And sometimes it works and sometimes it doesn't. And I feel very bad for the kids. And I try to do everything else that I can do without the meds. And sometimes they're very against stimulant meds, right? So maybe we'll try to do a non-stimulant, and say, look, this med is not addictive. It doesn't have any of that potential. That's another way to approach it sometimes. If they can even take it, it's hard, because if they're little and they can't swallow a tablet, it becomes very difficult to do a non-stimulant, but it's hard. And I laugh that you asked me that, because I have warring, I don't do them. Someone's asking about urine drug screens. I don't really do them. And I do worry sometimes, about the patients, but the way that we're set up in the practice, it's really not something that we would do. I suppose if I really, really thought, if I had a kid who came in, I've had parents coming in reeking of marijuana, but I haven't had a patient come in reeking of marijuana yet. I suppose they could. I do. I'm a peds neuro, so it's a little harder, but I suppose if someone did come in reeking of drugs, or I really thought they were on drugs, I would send one and then possibly cut them off from their meds, or just have a long discussion with them. It's not something, for us, again, being kids, the parents often control the meds too. So, and I try to make them cognizant of the fact that these are meds of abuse, and again, that's why everyone gets I use all the bad words when they go off to college. I mean, you're all adult doctors, I hope, here. And I'm like, I said, if I suspect even a little bit you are giving these to other people, you're done. I really try to put the fear of God in them, and like I said, some people really take their meds every day. It just helps them keep their shit together, frankly. And they really depend on their meds. But I'm like, look, nope, you just don't, it's not gonna happen. I try to, and again, I don't know, I'm this tiny, overweight little woman but I do try to put the fear of God in them a little bit. I try. I'm sure they're doing things that I've told them not to do. What am I gonna do? But I watched, we do check the refills. We do, in New York State, I'm in New York State, so they're very, very cogent of refills, right? There's a New York State prescription monitoring system that you're supposed to check when you refill. I often, even though it's sort of the law, sometimes I'll just check when I refilled it. And if it's like 2 weeks ago, I'll be like, why are you asking me for this refill? It's way too early, you know, and I'm very cogent of that. And I work with an nurse practitioner who's wonderful, and she's very also cogent of, you know, the refills and things like that. It's hard. It's really hard.
Well, Dr. Silver, thank you so much. This was
Sure.
fantastic. I don't see any more questions.
I'm like, I also I also realized all the stuff that I have to add to my slides.
It's great
When
job.
I think I'm good, and then I see that I'm like,
Yeah.
oh, I want to add this, I want to add that. So thank you guys for letting me do this, and that way I can also update stuff and make it better. All right, thank you guys so much.
Thank you.